but we have to discuss one important chapter of medical microbiology, that is Streptococcus. In our last class by Dr. Shah, he discussed about the beta hemolytic Streptococcus, especially Streptococcus pyogenes. And here today I will discuss the other beta hemolytic Streptococcus, which is very much important in today's scenario, where the increased number of cases are now seen with this special type of beta hemolysis group and other hemolytic group like alpha hemolysis and gamma hemolysis group. So, as you know from our last class, the Streptococcus, they are classified by their special capacity of producing hemolysis on blood agar. The unique characteristics of Streptococcus, not only Streptococcus, but there are so many other organisms which are also responsible for producing or can produce hemolysis on blood agar. But by far Streptococcus is one of the most important microorganisms. Streptococcus is classified, they are gram-positive organism, catalase negative, and they are classified by Rebecca Lancefield. And this classification is purely on the basis of C carbohydrate present on the cell wall of Streptococcus. So, on the basis of the cell wall carbohydrate, C carbohydrate, they are classified by Rebecca Lancefield, and this classification is a serologic reaction, antigen-antibody reaction, where Rebecca Lancefield very nicely collected the C antigen from the cell wall by autoclaving and enzymatic reactions, and with the help of capillary tube, this particular agglutination was conducted. And on the basis of that, the Lancefield classification is A to V, excluding I and J. Now, you can ask me that, sir, why I and J are excluded? This is a very nice story, that at that time, during the invent of this thing, classification, I stands for international unit and J starts with the name of the different national and international journal. So, technically the scientific committee, they recommended Rebecca that it is better not to include I and J. So, I and J are excluded, and from A to V 20 others are included. So, with this, the beta hemolysis producing group, that means the clear hemolysis surrounding the colony, is known as beta hemolysis. No RBC persist, all the RBC surrounding the group of the colony are lysed. And the alpha hemolysis, where there is partial hemolysis, there is green discoloration surrounding, and this is alpha hemolysis, and no hemolysis means nothing. Now, in this group, the beta hemolysis group on the basis of Lancefield classifications are 20, excluding I and J, and group A we have already discussed is that Streptococcus pyogenes. And group B, this particular organism, Streptococcus agalactiae, gradually increasing in at present condition. There is heavy colonization in the maternal genital tract, and subsequently the baby, the newborn baby is affected. The baby present with a very early onset symptoms. Within a day or two, the baby develop signs of meningitis and septicemia. So, it is a very challenging situation where the clinicians they must act, and the microbiologist who have to diagnose this case. What we see that the maternal passage is started with this group B, agalactae, and the newborn's respiratory tract, the nasal cavity, anterior nares, their auditory meatus, the respiratory tract inside the oral cavity, everywhere there is an increased incidence or increase. If you take the swab, that is the population of agalactae has increased. So with this, we can confirm that this is a case of Streptococcus agalactae infection and immediate treatment is required. But the tragedy is that even we start the antibiotics with penicillin for Streptococcus and cephalosporin group, the death rate is no less than 50%. So considering this challenge of the recent days, Streptococcus agalactae is very important for the gynecologist and as well as for the other clinician to identify it and to take proper action to preventive care of the childbearing mother. So neonatal sepsis and meningitis not only restricted to the newborn, also in case of adult, there are the possibilities of sepsis and endocarditis. If their possibility of infection is high and there is chance of this endocarditis, and in case of adult, in case of endocarditis, sepsis and endocarditis is a possibility of this Streptococcus agalactae infection. The identification depends on the classical streptococcal presentation, that is if you do the gram stain, you will see the cocci, gram positive cocci in chain, and a special test, a biochemical test known as the CAMP test, done by Christie, Atkins, Munch and Peterson. They have performed a typical test of identifying this Streptococcus species, where if you see that this is the blood agar, this is the blood agar media, where with the recent a new strain of Staphylococcus aureus, Staph aureus, a streaking is done here with Staphylococcus aureus, new colony, and with agalactae perpendicularly, Streptococcus agalactae, there is increased zone of hemolysis is seen. In blood agar, Staphylococcus can produce hemolysis due to the presence of beta hemolysin of Staphylococcus. So it can produce hemolysis due to different type of hemolysis Staphylococcus, and especially the beta hemolysis of Staphylococcus. But here the beta hemolysis also produced by Staphylococcus, Streptococcus agalactae, and the accentuation of the hemolytic zone, the area, there is accentuation of the hemolysis, this area, increased hemolysis is a clearly indication of that this is Streptococcus agalactae, and this test is known as CAMP test, Christie, Atkins, Munch, Peterson test. I have the slide with me, I will show you. So this test is very important test, other than hippuric acid test and other biochemical tests are also there. Streptococcus viridans is alpha hemolytic, and very recently the increased incidence of endocarditis has been noticed with this particular group of streptoviridans. They are mostly associated with dental cases, dental extractions. So many species have been identified with sanguis, equis and mutants. They are responsible for dental caries. What carbohydrate usually we take, they are broken down to dextran, and from there this particular material produce dental plaque over the dentine, and increased acid secretion from the carbohydrate is also the causative agents or aggravating factor. So, with the dental infection, there is possibility of endocarditis during dental extraction and direct endocarditis in native valve and prosthetic valve. There is a possibility of increased infection. We will discuss it in the light of endocarditis later on. And Enterococcus is a causative agents of UTI and endocarditis. Another group is gamma hemolysis, that is no hemolysis on blood agar. So, beta hemolysis group, Streptococcus pyogenes and Streptococcus agalactiae, these two are important. For alpha hemolytic group, Streptococcus viridans is important, and for the gamma hemolytic group, Enterococci, this is very important for you. Only these four for you is important. So, Enterococci, from the name Enterococci, you can understand that it is present in the intestine, normally present in the intestine. But if it enters the urinary tract, it can produce urinary tract infection, and in case of the endocarditis, the endocardium is affected. The condition is grave in case of enterococcal endocarditis, and Enterococcus, the peculiar shape of Enterococcus is diploid arrangement, diplococcus, leaf-like, and the few group characters are there for the Enterococcus. These 4 to 5 characters are to remember to identify Enterococcus. Enterococcus, they can stand a pH level up to 9.6, can tolerate sodium chloride up to 6.5%, and their special character is their drug resistance. They are intrinsically resistant to penicillin. They are intrinsically resistant to certain aminoglycosides and cephalosporin, and variable resistance to different aminoglycosides. And now they are also growing resistance to vancomycin. A special gene VAN A, VAN B is responsible for producing the vancomycin resistance and teicoplanin resistance. So, the real challenge and the main therapeutic target for a clinician to overcome the enterococcal infection is to combine a cell wall antibiotic with an aminoglycosidic antibiotic. A cell wall antibiotic like penicillin and cephalosporin is combined with aminoglycosides like gentamicin and amikacin. And if it is not possible, then the vancomycin and aminoglycosides is another choice, or teicoplanin or aminoglycosides are the other challenge. And these are costly and very toxic drug. A special test is usually performed where the MIC, the minimum inhibitory concentration of a drug, is estimated. The minimal inhibitory concentration, if with gentamicin or streptomycin, is less than 500 mu, then we can combine, and then we can expect a synergism of a vancomycin group with an aminoglycoside group. And if it is not there from the microbiological desk, if microbiologist desk, if the report is negative or the organism is high level resistant to gentamicin group or aminoglycosides group, then it is really difficult to treat the endocarditis of Enterococcus origin. The vaginal tract and rectal carries the group B Streptococcus or GBS. The group A Streptococcus is called group A, GAS, gash, and this particular group is called GBS. The GBS infection common in neonates and pregnancy, as I told earlier. It is recognized as a major cause of neonatal sepsis and meningitis. Infections in pregnancy lead to peripartum fever, endometritis, and puerperal sepsis. Infection in adult involve elderly and people with underlying chronic illness, diabetic mellitus, and malignancy. The common infections are cellulitis, soft tissue infections. The early onset type, in case of newborn, present in the vaginal flora, 25% cases present in vaginal flora when the vaginal flora is colonized with this particular Streptococcus agalactiae. Then the factors are associated factors are early rupture of the membrane, prolonged labor, and if there is heavy colonization, then the early onset type of infection sets in. And septicemia, pneumonia, meningitis with 50 to 70% mortality. Most important serotype revealed is serotype 3, 1A, 1B by C. There are so many serotypes are there. So the early onset meningitis, just after birth, within 2 days, within 48 hours to 72 hours, if there is a signs and symptom of meningitis or septicemia, always think that it is a maternal birth passage infection, and probably this is with Streptococcus agalactiae. The late onset type, this particularly develops from the hospital caregivers, from the doctors, from the nurses, and they develop between the 2nd and 4th week of life. This is usually hospital acquired and not so serious, but high incidence of neurological deficit can occur. Neurodeficiency disease can occur from this type. Lab diagnosis, isolation of GBS from blood culture, and CSF blood culture is the only method. In case of when you are suspecting septicemia, meningitis, you have to go for blood culture first. The first prescription is blood culture, and with this we have to take at least 2 samples of blood, 5 to 10 ml of blood in sterile environment, and in brain heart infusion agar or brain heart infusion broth, maybe in castanedas, biphasic media. So with this you will be able to identify this GBS, which is catalase negative and having these characteristics of Streptococcus pyogenes. How will you differentiate Streptococcus pyogenes with Streptococcus agalactiae, because both these two are from group B, that means beta hemolysis group. Under the beta hemolysis group, we are getting this A and B. A is Streptococcus pyogenes and B is Streptococcus agalactiae under the group of beta hemolysis. Lancefield group A, Lancefield group B. The bacitracin sensitivity in pyogenes is case of sensitive, it's positive, and agalactiae is resistant. CAMP test that I have mentioned, that Christie, Atkins, Munch and Peterson test is negative for Staphylococcus pyogenes and agalactiae is positive. Beta hemolytic colony is almost same, pinpoint, very difficult to identify and difficult to separate them. So the important tests are this bacitracin sensitivity and CAMP test, by which you will be able to identify the group B. This is the picture of the CAMP test, beta hemolysis, bacitracin resistance, no extra zone of hemolysis surrounding the disc, and this is the increased zone of hemolysis. This is the Staphylococcus aureus streaking on the blood agar plate. We have done this particular test in our laboratory, and one thing that it is not at all positive with all Staphylococcus aureus. Only one particular strain of Staphylococcus aureus, that is known as Plagen strain, which is really positive with this CAMP test. So Staphylococcus aureus, specifically Plagen strain, can show this CAMP test positivity. So streaking with Staphylococcus aureus and perpendicular to this is the agalactiae. The test is also positive, test beta suspected cases of this organism. It is the control, and this is the suspected case, it is also positive, and Staphylococcus pyogenes is negative. only beta hemolysis is seen, but there is no accentuation here. So, with the help of the Kemp factor, the accentuation occurs. Treatment is penicillin, penicillin plus gentamicin, drug of choice for all GBS infection. But I can tell you that even you start the penicillin and all sorts of treatment with this particular group, if there is meningitis or septicemia, survival rate is only 50 to 60% with this therapy. There are other groups of these agalactiae, subspecies equisimilis. These are not important for you. Group F Streptococcus, one thing to say that there is one Streptococcus mg, the alpha hemolytic strain belonging to this group, and the demonstration of antibodies to Streptococcus mg in patient sera is used for diagnosis of primary atypical pneumonia caused by Mycoplasma pneumoniae. Later on you will read the atypical pneumonia where the culture is negative. This atypical pneumonia you can be able to identify with this Streptococcus mg strain. Here is group D. Group D Streptococci comprise of Enterococci, that is fecal Streptococci, and non-Enterococci group. Enterococcal group is, there are so many species, but these two particular species, E. faecalis, and is very much common in clinical specimen, and E. physium, it is mostly drug resistant. So, Enterococcus faecalis and Enterococcus physium, these two, remember, these two are very important for us. Clinical specimen, we identify often we found this E. faecalis, but E. physium is drug resistant. And in our clinical practice, we identify these two by a very simple test that is known as imipenem test. If imipenem is positive, then this faecalis and resistant in case of physium. That is a bedside test for identification. The group characters of Enterococcus, this is asked in the oral examination. They tell us the group characters of Enterococcus. I have mentioned this, that can grow in presence of 40% bile, can tolerate 9.6 and can withstand 6.5% of sodium chloride, and can grow at 45 degrees centigrade, can withstand temperature also 45 degrees centigrade or even 60 degrees centigrade for half an hour. So, these are the four group characters of Enterococci, Enterococci physium, faecalis. Compared to Enterococcus, the non-Enterococcal group D, they are more susceptible to antibiotics such as penicillin, because Enterococcal group are resistant to this group of drugs, and they do not grow in presence of 6.5% salt, less pathogenic to humans and not a part of the intestinal flora, the other group. Diagnosis: the gram-positive oval cocci arranged in pairs and at an angle to each other. Blood agar is non-hemolytic colonies. The typical character of Enterococcus is like that. Gram-positive oval cocci, and at an angle to each other, and blood agar non-hemolytic colonies, McConkey agar small pink colonies. Bile esculin media is positive and POIR reactions positive. Special characters are important. This is drug resistancy. This is important for pharmacology also. Intrinsically resistant means genetically resistant, and intrinsically resistant penicillin, cephalosporin, monobactam, low level resistant to aminoglycosides. And resistance to aminoglycosides in endocarditis, a cell wall antibiotic often combined with aminoglycosides, and this is really difficult if the synergism is not there, that is MIC is remain less than 500, then the synergism is possible, that is differential resistant. And in case of penicillin and ampicillin resistancy, we have to try vancomycin and teicoplanin. This particular group, that is viridans group, they are heterogeneous. They do not possess a group specific carbohydrate. At least 5 species of virulent streptococci are recognized: Salivarius, sanguis, mutans, mites, and milleri. They are not classified under this Lancefield group, isn't it? Lancefield group is classified only beta hemolytic group. That is, those colony, those organisms, they can produce beta hemolysis on blood agar, they are classified by Lancefield, not the whole group of Streptococcus. So, other groups of Streptococcus, they are classified with this alpha hemolysis, and the dietary sucrose is important here by sanguis and mutants. They break down this to sucrose, acid, and tough adhesive dextran. And acid damages dentine, and dextran binds together with food debris, epithelial cells, mucus, and bacteria to form dental plaques, leads to caries tooth. In person with predisposing factors such as valvular disease of heart, they may cause infective endocarditis. What is bacteremia? When bacteria is present in the circulation, but they are not reproducing stage. So, bacteria, simple bacteria, they are present in the system is bacteremia, and septicemia, multiplying organism in blood, is septicemia. Now, the causative agents of septicemia: Salmonella typhi, causative agents of typhoid fever, the Hasek group of organism, Haemophilus, Atrophius, and Aggregatobacter, Cardiobacter, Echinella corridens, and Kingella kingi. These are the group: Escherichia coli, Klebsiella, Pseudomonas, Staphylococcus, Listeria, monocytogenes, and Neisseria meningitidis. They can produce the septicemia, but we have to discuss about endocarditis. Now, CBME based question is this, and this question will come in your examination, that what is endocarditis, how to manage endocarditis with the latest antibiotic, and how will you go for diagnosis of endocarditis. This is clinical oriented question, and endocarditis means the infections of endocardial surfaces of heart characterized by bulky friable vegetations. Bulky friable vegetations composed of platelets, fibrin, inflammatory cells, and organisms. Is it clear? This is the definition of endocarditis. Infection of endocardial surface of heart characterized by bulky friable vegetations composed of, how the vegetation is composed? The vegetation is composed with platelets, fibrins, inflammatory cells, and the organism itself. The vegetations are commonly present in hard valves, native or prosthetic, and or mural endocardium. What is mural endocardium? Endocardium where there is no valve, the other area of endocardium without valve. That is mural endocardium, single layer of endothelial cells that cover the membrana propria of heart, non-valvular endocardium. So, the vegetations are commonly present in heart valves and on mural endocardium. This is endocarditis. What is acute and what is subacute endocarditis? Definitely we are going to ask you in the oral examination as well as in the theory questions. Acute and subacute endocarditis. Subacute endocarditis, it progresses the short weeks to months. It's very slow, not short, it's very slow. But in case of acute, it is very rapid. The heart valve, subacute endocarditis, their target is on the defective and previously damaged heart valve. But acute, the heart valves are normal. The causative agents is streptovirulence, that streptovirulence, alpha hemolytic group. Streptococcus sanguis, mutants, mites, and Enterococcus faecalis. Those two Enterococcus, Enterococcus faecium and Enterococcus faecalis, out of which Enterococcus faecalis responsible for subacute endocarditis. Please don't forget. Acute. Causative organism, the first of the list is Staphylococcus aureus. Streptococcus pneumoniae, Streptococcus agalactiae and Streptococcus pyogenes. They are responsible for the acute endocarditis, which is very rapid in onset. Recovery after antibiotics, the rate is very good, but here in acute, mortality and morbidity even after therapy is high. Occurrence, subacute is more common, acute less common. Please write it, and you have to write it very clearly. লিখে নাও, পরীক্ষায় আসবে। এন্ডোকার্ডাইটিস একটা ভীষণ ভালো প্রশ্ন, পরীক্ষায় আসবেই আসবে। বারে বারে পরীক্ষায় এসছে, আবারও আসবে। হয়েছে? The pathogenesis from the primary site through bloodstream to heart. From the mouth, the site of infection is streptovirulence, the organism is streptovirulence from oral cavity. From the skin, this is Staphylococcus aureus. From the intestine, it is Enterococci. From the respiratory tract is the Hasse group. 30% in normal heart and 70% in previous cardiac disease. The congenital valve prosthesis, previous cardiac disease means congenital valve prosthesis, the rheumatic valvular disease, and drug abuse, those taking intravenous drug. So the chances are more, and the site of infection is this. Laboratory diagnosis. The modified Duke criteria is used here. You have to read the Duke criteria. The Duke criteria is based on the blood culture and few symptoms. Please read Duke culture from your textbook. And these major and minor criteria are important. For definitive endocarditis, 2 major criteria and 1 major or 3 minor or 5 minor criteria are required. The 2 sets of blood culture more than 12 hours interval. Now one blood culture, and after 12-hour interval another blood culture from another site is required. Each pair of bottles collected from different site. Every time you have to collect 2 bottles at least, if not 3 bottles. But collecting so many such an amount of blood is really difficult. So at least 2 bottles, one for aerobic culture, another for anaerobic culture. So in case of writing blood culture, rather in blood culture bottle, we have to write, we will go for 2 simultaneous blood culture, 5 to 10 ml blood in each bottle from 2 different sites, at least 1 hour interval, but where the endocarditis is suspected after 12 hours interval. Why? The chance of getting commensal in 1 vial is not diagnostic. So if you get the commensal organism in consecutive 2 vial, then only the commensal, say for example, is Staphylococcus epidermidis, which is usually present in skin. If we get Staphylococcus epidermidis in 1 vial, this is not confirmatory. We have to get 2 Staphylococcus aureus and to suspect that whether the patient is immunocompromised or not, because epidermidis, in spite of commensal, it can produce disease in case of immunocompromised patient. So that's why I have already mentioned in my earlier classes that at this particular time it is really difficult to identify the organism, which one is causative, which one is not commensal, and which is causative disease, which one is causative, the causative agents of the disease. To identify them between the commensal and the pathogen, the differentiation is almost lost after HIV. So the identification of commensal organism in consecutive 2 blood culture specimen is confirmatory. So that's why we have to go for 2 bottle. 1 bottle, 1 Staphylococcus epidermidis is not at all confirmatory. If in 2 bottles, then it is confirmatory. That's why 2 consecutive samples is required. Now each pair of bottles collected from different sites. Before starting antibiotics, although now we are adding SPS, polyanethyl sulfonate, that is we are adding, and which neutralizes the antibiotic present in the system, in the circulation. When the patient is getting antibiotics and you are collecting blood from the patient, then there is chance of no organism isolated from the blood culture. So empiric therapy is always there. When the patient doctors are suspecting one patient is suffering from septicemia, definitely they are going to start antibiotic from the very earlier phase. So when they are starting antibiotic, that is called the empiric therapy. Then you are taking the blood sample on the next very day, the blood where antibiotics are there, and the probability of getting an organism is less. So to neutralize that, we have a special component, that is SPS, known as SPS, that has been added in the blood culture bottle, and that to neutralize the antibiotics, especially aminoglycosides. So before starting antibiotics, and it is preferred, and repeated culture required, and the brain heart infusion broth is the media of choice. What is used in blood culture? The brain heart infusion broth is used usually in blood culture. The colony character, if you get one colony in blood agar media, that is beta hemolysis, but that is pinpoint colony beta hemolysis, then your suspicion is Streptococcus. The pinhead colony beta hemolysis, Staphylococcus. Colony pinpoint but no hemolysis, then Enterococcus. No hemolysis, gamma hemolysis in the group of Enterococcus. Alpha hemolysis. Is it clear? So that is so important in cultivation in blood culture. That's why it is so important. And gram staining. Gram positive cocci in group. Staphylococcus, gram positive cocci in group, gram positive cocci in chain, Streptococcus, isn't it? Biochemical tests. The selective media of Staphylococcus is mannitol salt agar. Go for coagulase test, go for catalase test. Catalase test is positive for Staphylococcus, negative for Streptococcus. So simple, by a simple method, by observing the colony character, by observing the growth. First the growth, then the hemolysis pattern. If there is Staphylococcus, there is possibility of pigmentation, golden yellow pigment in case of Staphylococcus aureus, isn't it? So the colony character, pigmentation, motility, all cocci are usually non-motile. So motility here is not important. So in case of Escherichia coli, Klebsiella, you have to identify the motility pattern of this. And here in case of gram positive group, Streptococcus in chain and Staphylococcus in group. These are the primary suspicion. No? Then automated blood culture system is also there. They only give the signal that now within 4 hours it is positive. If the sample is positive in 4 hours, then bacterial load is high. If the sample is positive on the next day, the bacterial load is less. So here, one important thing is to convey to the clinician on the part of the microbiologist is that when the growth is coming, often they missed it. But it's a very important clue for the clinician just to inform them that when the culture is, we are getting this culture positive. After 4 hours, after 6 hours, after 8 hours, inform them. They can calculate the bacterial load. So automated blood culture is important during that calculation, regarding this calculation. They can show it that after 4 hours, the automated system is positive. Now we have to go for the identification in plate, in blood agar, and in case of McConkey agar, whatever the media, media of choice, you select it and go for your primary suspicion to identify it. And finally, the antibiotic sensitivity test. As I have mentioned, in case of Enterococcus, the drug resistance is more. So in Enterococcus, we often perform for synergism. As I mentioned that the enterococcal infection in enterococcal endocarditis, the treatment with cell wall antibiotic, that is penicillin and vancomycin, is combined with aminoglycoside antibiotic. So there is a synergism, what you expect, that synergism is there, and that is required to cure your patient. So for identifying the synergism, we have to go for the high level resistance. That is a high level disk that is available. The high level sensitivity test is done with aminoglycosides, with streptomycin and with gentamicin. High level sensitivity test is done with gentamicin and streptomycin to identify the synergism. If the high level gentamicin test is positive, then don't go for resistant, then do more than 500, then don't go for the synergism. Then the drug of choice is vancomycin. The vancomycin resistance is also there, is emerging. And so teicoplanin and combined with aminoglycosides as another therapeutic choice. So this is really difficult to identify at your stage, and we will read the pharmacology. After that final examination time, you will be able to understand the entire picture. But I have to tell you everything because the treatment of endocarditis is a challenge for clinician, and the course is CBME orientation, and that's why I have to tell you the picture of the Streptococcus, and this particular group is famous for their drug resistance. And even if in spite of adequate therapy, adequate treatment, the failure rate is high. So that is all about the Streptococcus and other Streptococcus, only Streptococcus pneumoniae. That we will discuss on the next day. Any question? তাহলে একবার বলি 2 মিনিট বাংলায় সুবিধা হবে। স্টেপ্টোকক্কাস গ্রুপটাকে আমরা ক্লাসিফাই করেছি ব্লাড আগার মিডিয়ায় কালচার করে 3 ভাগে ভাগ করেছি, আলফা হিমোলিসিস, বিটা হিমোলিসিস আর গামা হিমোলিসিস। আলফা হিমোলিসিস যারা অল্প হিমোলিসিস করে তারা আলফা হিমোলিসিস, যারা পুরোটাই হিমোলিসিস করে কলোনির চারপাশে, এই হিমোলিসিসটা কোথায় হবে? কলোনির চারপাশে ছোট ছোট কলোনি হয়, পিন পয়েন্ট কলোনি হয় স্ট্রেপ্টোকক্কাসে, আর স্ট্যাফিলোকক্কাসে পিন হেড কলোনি হয়। তো এই স্ট্রেপ্টোকক্কাসের কলোনির চারপাশে পুরো হিমোলিসিস হলো, সেটাকে বলে বিটা হিমোলিসিস। কি করে কনফার্ম করা যায় বিটা হিমোলিসিস? স্যার ওই বিটা হিমোলিসিসের চারপাশে যেখানটায় একেবারে জোন অফ হিমোলিসিস হয়েছে সেখান থেকে ম্যাটেরিয়াল নিয়ে যদি দেখি একটাও আরবিসি পাবো না, সব আরবিসি গুলো লাইজড হয়ে গেছে। আর আলফা হিমোলিসিসের জায়গায় যদি ম্যাটেরিয়াল নিয়ে দেখি মাইক্রোস্কোপের নিচে, তাহলে কয়েকটা আরবিসি দেখবো গোটা গোটা আছে আর কয়েকটা পার্শিয়ালি ভেঙে গেছে। তাহলে এই হচ্ছে আলফা আর বিটা হিমোলিসিসের পার্থক্য। তাহলে একটা গ্রুপে আলফা হিমোলিসিস, তার মধ্যে কারা যাবে? স্ট্রেপ্টোকক্কাস ভিরিডেন্স যাবে আর স্ট্রেপ্টোকক্কাস নিউমোনিয়া যাবে, যারা পার্শিয়াল হিমোলিসিস করে ব্লাড আগারে। কেমন? আর ব্লাড আগারে পুরো হিমোলিসিস করে কারা কারা? তার মধ্যে বলতে গিয়েই ল্যান্ডসফিল্ড ক্লাসিফিকেশন এসে গেল। ল্যান্ডসফিল্ড বললেন দাঁড়াও দাঁড়াও এটাকে ক্লাসিফাই করি, অনেকগুলো আছে। তো অনেকগুলোকে ক্লাসিফাই করতে গিয়ে বিটা হিমোলিসিস যারা কমপ্লিট হিমোলিসিস করে তাদেরকে ক্লাসিফাই করলেন এ থেকে ভি অবধি, কারা কারা নেই, আই আর জে নেই, এই দুটোকে বাদ দিয়ে 20টা ভাগে ভাগ করলেন। তার মধ্যে আমাদের জন্য ইম্পর্টেন্ট হচ্ছে এ আর বি, অন্তত পড়তেই হবে। আরেকটা গ্রুপ এলো গামা হিমোলিসিস গ্রুপ, যারা কোমল হিমোলিসিস করে, তাদের মধ্যে ইম্পর্টেন্ট কে এলো? এন্টেরোকক্কাই, তাই না? এন্টেরোকক্কাই এলো। তাহলে এন্টেরোকক্কাই যদি ধরো, তাহলে এন্টেরো নামটা হচ্ছে পেটে, তাহলে এন্টেরোকক্কাস কোথায় থাকে? পেটে থাকে। এবার এন্টেরোকক্কাস কেমন দেখতে হয়? জোড়া পাতার মতো হয়, অ্যাঙ্গেলে থাকে, সুন্দর ওভুলার, দেখলেই বোঝা যায়। তার সঙ্গে সঙ্গে বাকিগুলো লম্বা চেনে থাকে, স্ট্রেপ্টোকক্কাসের গ্রুপ প্যাটার্ন চেনে থাকে। এন্টেরোকক্কাসের গ্রুপ ক্যারেক্টারিস্টিক্স গুলো বলে দেওয়া, সেগুলো বলেছি। পিএইচ স্ট্যান্ড করতে পারে, 6.5% সোডিয়াম ক্লোরাইড স্ট্যান্ড করতে পারে, হিট স্ট্যান্ড করতে পারে। তুমি 60 ডিগ্রিতে রেখে দাও, 30 মিনিট বেঁচে যাবে, তারপর কালচার করো, গ্রোথ এসে গেল, তাহলে মারাত্মক। তাকে অ্যান্টিবায়োটিক দিয়ে মারাও মারাত্মক। যে মরছে না এত হিটে, সে তো আর অ্যান্টিবায়োটিকে সহজে মরবে না, তাই সে পেনিসিলিন রেজিস্ট্যান্ট, অ্যামিনোগ্লাইকোসাইড রেজিস্ট্যান্স। তার জন্য তাকে একসঙ্গে থেরাপি করতে হয়, একটা সেল ওয়ালের সঙ্গে একটা ডিএনএর উপর কাজ করছে এমন একটা অ্যান্টিবায়োটিক কম্বাইন করে লাগিয়ে দিতে হয়। তারা কারা? পেনিসিলিন আর জেন্টামাইসিন, ব্যামিকেসিন। না হলে ড্রাগ রেজিস্ট্যান্সি প্যাটার্ন দেখে কি করতে হবে? অন্য কম্বিনেশনে যেতে হবে। ভ্যাঙ্কোমাইসিন ইউজ করতে পারো, টিকোপ্লেনিন ইউজ করতে পারো। এই হয়ে গেল এন্টেরোকক্কাস গ্রুপ। এবার চলে এসো বিটা হিমোলিসিস গ্রুপটা। আগালাক্টির কথা বলছিলাম। আগালাক্টির মোস্ট ইম্পর্টেন্ট ফিচার্স হচ্ছে কি? ম্যাটার্নাল জেনিটাল প্যাসেজে থাকে, 25 to 40% কেসেই থাকে। ফলে চাইল্ড বার্থের সময় যদি পপুলেশন আরো বাড়ে, তাহলে কিন্তু ফিটাসের ইনফেকশন হওয়ার পসিবিলিটি আছে। স্পেশালি সিজারিয়ান সেকশনের ক্ষেত্রে আমরা দেখেছি বাচ্চার কিন্তু মেনিনজাইটিস বা সেপ্টিসিমিয়া হওয়ার পসিবিলিটি থাকে। গাইনোকোলজিস্ট যারা হবে তাদের সাবধান। বাচ্চা জন্মাবার 48 ঘন্টার মধ্যে বা 72 ঘন্টার মধ্যে বাচ্চার যদি এরকম ফাইন্ডিংস গুলো আসে যে সেপ্টিসিমিয়ার ফলে আছে বা মেনিনজাইটিসের ফলে আসে, তাহলে কিন্তু তোমাকে সতর্ক হতে হবে। সতর্ক হয়ে দেখা গেছে যে অ্যান্টিবায়োটিক থেরাপি শুরু করার পরেও বাচ্চা 50%-এর বেশি বাঁচে না। তাহলে এটা হচ্ছে আর্লি অনসেট সেপ্টিসিমিয়া, আর্লি অনসেট মেনিনজাইটিস। এটা 2-4 দিনের মধ্যেই হয়ে যাবে জন্মাবার। আর লেট অনসেট যদি হয়, তাহলে অনেকদিন ধরে মা ভর্তি আছে হাসপাতালে, সেখান থেকে বাচ্চার হলো, হসপিটাল কেয়ার গিভারদের থেকে হলো, এটাকে লেট অনসেট বলে। লেট অনসেট অত বিপজ্জনক নয়। বেশ, তাহলে বাকি পড়ে রইল কে? আলফা হিমোলিটিক গ্রুপটা। আমরা তো বিটাও আলোচনা করলাম, আমরা গামাও আলোচনা করেছি, আলফা পড়ে রইল। আলফায় কারা কারা আছে? স্টেপ্টো ভিরিডেন্স আর নিউমোনি। ভেরি গুড, এই দুটো আছে। নিউমোনি তো নিউমোনিয়া করে। পরীক্ষায় জিজ্ঞেস করলাম আমরা যে নিউমোনিয়া কারা কারা করে, নাম বলো। স্টুডেন্ট চুপ করে রইল, তো খারাপ লাগে। নিউমোনি নাম আছে, এর পিছনে যত সব ব্যাকটেরিয়াই করে স্যার। তারা কারা কারা? স্ট্রেপ্টোকক্কাস নিউমোনি, ক্লেবসিয়েলা নিউমোনি। এগুলো বলতে না পারার তো কিছু নেই, তো নামেই রয়েছে, শুধু নামগুলো বলে দাও, তাহলেই এক্সামিনার খুশি। রেসপিরেটরি ট্র্যাক্ট ইনফেকশন কি করে? আরে বাবা কিছু মনে নেই তো, এই স্ট্রেপ্টোকক্কাস নিউমোনি, ক্লেবসিয়েলা নিউমোনি, এগুলো তো করেই করে, না বলতে পারার তো কিছু নেই। রেসপিরেটরি ইনফেকশন কারা করে? তাহলে স্ট্রেপ্টোকক্কাস নিউমোনি মূলত কি, স্ট্রেপ্টোকক্কাস ভিরিডেন্সের মূলত কি করবার ব্যাপারটা বললাম, এদের কয়েকটা গ্রুপ রয়েছে, তার মধ্যে 4টে স্যাঙ্গুইস মিউট্যান্টস, এগুলো খুব ইম্পর্টেন্ট। ডেন্টাল ইনফেকশন করে, দাঁতে প্লেক হয়, হলুদ হলুদ হয়, ডেন্টাল সার্জনরা সেগুলো রিমুভ করে। ডেন্টাল প্লেক বা টুথ এক্সট্রাকশন করবার সময় ওখান থেকে ওরা ইনফেকশনটাকে সিস্টেমে নিয়ে চলে যায়। রোজ দাঁত মাজার সময়ও একটুখানি হতে পারে, দাঁতটা একটু ব্লিড করলো, একটা ধারালো কিছু দিয়ে তুমি দাঁত মাজছো, একটু ব্লিড করলো, সেখান থেকেও হতে পারে। যাই হোক, চান্স কম সেখান থেকে। তো যাই হোক, দাঁত তোলবার সময় সেখান থেকে ইনফেকশন চলে গেল। এবার তোমার আগে থেকে কিছু একটা ভালভুলার ডিজিজ আছে, তাহলে সাবঅ্যাকিউট হওয়ার চান্স বেশি। স্লোলি সেখানে ভেজিটেশন হবে, ভেজিটেশন কি লিখে নিয়েছো সেই জিনিসটা হবে। আর যদি না থাকে, র্যাপিডলিও হয়ে যেতে পারে, সরাসরি ব্যাকটেরিয়াল লোড বেশি, সরাসরি হয়ে গেল। তাহলে হয়ে গেলে খুব র্যাপিডলি থেরাপি শুরু করতে হবে, আমাদের আইডেন্টিফাই করতে হবে তো তাড়াতাড়ি যে স্ট্রেপ্টোভিরিডেন্স থেকে হয়েছে। তাহলে স্ট্রেপ্টোভিরিডেন্সের এই ভয়টা রয়েছে। দুটো জিনিস, ডেন্টাল প্লেক, আরেকটা হচ্ছে এন্ডোকার্ডাইটিস।